Hi, everyone. Welcome to the CG podcast, where we explore the legacy of the COVID-19 pandemic on science, society, and public health policy. I'm delighted to have my guest with me today, Jacob Stegenga, who's a philosopher of science and medicine at the University of Cambridge. He's the author of a 2018 book by the interesting title of Medical Nihilism, which critiques the quality and completeness of evidence in medicine and ultimately argues that many medical interventions are oversold and overhyped. Great to have you on the podcast, Jacob.
Thanks for inviting me.
So let's dive right in here. The title, Medical Nihilism. Nihilism, nothing exists, so sort of a sense of philosophical meaninglessness. Why did you choose the term in relationship to medicine here?
Yeah, thanks. So the term is not connoting anything quite so dramatic as the standard term nihilism or nihilism, as some people call it. The general idea is the thesis that we should have low confidence in the effectiveness of medical interventions. So it's a kind of skeptical thesis about a lot of what medicine has to offer today.
Okay. And I mean, in the book, you actually say that this was a widely held view in the past, and it's only actually more recently, historically, that we have sort of society has shifted its sense of medical evidence. Can you just give us a sense of that argument?
Yeah, sure. So prominent thinkers sort of through the entire history of medicine, going back to ancient Greeks and all through the modern European period, through the 19th century, like serious thinkers about medicine have offered versions of a thesis like medical nihilism. And the term itself, therapeutic nihilism, was popular in the 19th century. Really important physicians like the dean of the Harvard Medical School called themselves therapeutic nihilists. And I would say sort of in the first half of the 20th century, that all fell out of favor because, in my view, medicine went through a series of breakthroughs. Medicine had its kind of golden era from, say, 1900 until 1950. So there were all these amazing breakthroughs in medicine, which for a time lent less credibility to this sort of skeptical thesis about medicine. There were ups and downs through the latter part of the 20th century, sort of aligned with some of the general kind of cultural trends in Western society. So, movements that were associated with sort of like opposition to capitalism, opposition to globalization, and stuff like that. But on the whole, most of Western society has inherited this sort of optimism about medicine that was warranted in the first half of the 20th century. In the last generation or so, a lot of very kind of core serious thinkers in medicine, like editors of medical journals, prominent medical professors, have started to write books and articles and give interviews that suggest a kind of return to this skeptical view about medicine. And it was that work in the last 25 or 30 years that really prompted me to write the book.
Okay. All right. And I mean, so kind of, thinking about the COVID pandemic, what was your general sense of the use of evidence, or did you feel like your thesis that medical nihilism was sort of becoming more prominent? Did you see that play out, or did you see the opposite occur? What's your kind of sense of the pandemic in terms of this thesis?
Okay, this is a really deep question, and there's really a lot to say about it. So I'll take a first pass, and we can revisit a few topics that come up. So I published the book in 2018. Of course, had no idea a couple of years later we'd be facing this pandemic, and obviously I had those years of work that went into the book when the pandemic arose. So I was in a position to be thinking, gosh, given the lessons of the book, how should we be thinking about this virus and the various policy responses to the virus? And part of my thinking is that we probably would have been way better off as a society had we been in a position to heed some of the lessons from the book. So just to kind of, one of course might expect that I would say that, but so some of the key ideas in the book are that medical research itself is shot through with various biases. The medical research agenda pursues certain kinds of interventions at the expense of others. So outside the context of the pandemic, the main kind of intervention that medicine pursues are pharmaceuticals rather than, say, lifestyle interventions. And that's all in the context of this kind of socio-political situation in which, like, there are big financial incentives for particular agents that promote these various features of medical research. And a lot of interventions, this is part of the argument of the book, a lot of interventions just have tiny effect sizes. So most of the widely used interventions in medicine have really small effect sizes. Another argument in the book is that we tend to underestimate the harms of medical interventions. So medical research is sort of tuned to exaggerate the benefits of medical interventions, but to underestimate the harms. So I had all of that sort of, in my toolkit from the work that went into the book. And as I saw the pandemic play out, it looked like a lot of those themes were arising during the pandemic.
Okay, what would be, let's say, the top 3 most striking examples that you can think of?
Okay, so good, thanks. So if we ask what are the most prominent interventions that were being pursued during the pandemic, it's pretty obvious. One was vaccines. 2 were all of the various kind of mitigation strategies, so non-pharmaceutical interventions, and 3 was pharmaceutical interventions. So those were the 3 sort of strands of development to attempt to come up with something to help during the pandemic. And I would say that on all 3 of those strands, benefits were overestimated and harms were underestimated. So the really clear example, and this is an example that's been explored on your podcast a lot in previous episodes, are the harms from the various mitigation strategies. So we should have been able to predict in advance that lockdowns would lead to educational challenges, would affect particular socioeconomic classes over others, would have like global consequences that should have been foreseeable. These are themes that have been explored on your channel before. So that's a really obvious case in which this one major stream of development for an intervention for COVID downplayed harms and very clearly overplayed benefits. I could keep going on this.
No, absolutely. I mean, and that's also the case for the COVID vaccines, which is a very emotive topic. And there's a number of like modeling studies that project 20 plus million people's lives being saved. And if you look under the hood of the assumptions of the models, they're exactly that. They're overstating benefits, and it's very difficult to get a clear-headed sort of sense of just how beneficial those vaccines were, and depending on the age, also, like, there's an age gradient. And that's something that we're actually interested in at Collateral Global, is looking at risk-benefit studies from a more critical perspective.
Yeah, good.
So, I mean, one of the things that you talk about in the book is evidence-based medicine, right? As this sort of movement, you're sympathetic to it, but you also critique it. Can you just give us a sense of your thinking around evidence-based medicine?
Sure. So the key idea with evidence-based medicine is that we should test interventions with what are called randomized control trials. These are typically thought to be the so-called gold standard for testing an intervention. Now, there's a lot of debate about whether or not they should be the gold standard, or whether or not there are particular conditions under which RCTs, randomized control trials, are in fact the gold standard. My view is that in general, it's a good idea to test interventions with RCTs. The criticism of RCTs in the book is not about RCTs in general per se, but rather about how particular RCTs tend to get performed. There's issues about using sloppy measuring instruments in RCTs, or hiding data from RCTs. So these aren't criticisms of RCTs per se, but rather just criticisms about particular flaws in certain RCTs. So the core idea about evidence-based medicine is we should be testing interventions with randomized control trials. And if we bring that notion around to the pandemic, there are a few implications. One is that when it came to non-pharmaceutical interventions and the various assumptions that went into modeling the impact of those non-pharmaceutical interventions, we had almost no RCTs to go on. So, for example, school closures, or border closures, or business closing, the various kinds of social policies that went into lockdowns. We really had no sort of gold standard evidence about what the impact of those interventions would be like. Now, there will be debates for generations about whether or not school closures did X or Y, but those are going to be post hoc evaluations of the impact of those various social policies and testing this sort of counterfactual scenarios, like what would things have been like had we done A instead of B, are extremely difficult. And that's the whole point of doing RCTs. So in my view, it would have been really good had we rolled out quality large-scale RCTs about the various social policies that were being proposed in a timely manner. Now, it's not that we didn't do that at all. There were some studies that attempted to do things like this. So, for example, there's the famous Bangladesh mask study.
Right.
Took 600 villages in Bangladesh, randomly allocated some of them to a mask group, some of them to a control group. There were 350,000 people randomized in this study. And sometime by mid-2021, we had this really well done, huge study giving us a little bit of evidence about whether or not masks were effective. Now, there's problems with that particular example that I could dive into that are really illustrative about medicine in general, but that's the point. So if we're speaking about evidence-based medicine, we need really well done trials to test the effects of interventions. One more quick thing to say about this is during the first, well, I would say the first 2 years of the pandemic, there was a huge push to look for pharmaceutical interventions to help COVID.
Yeah.
And that's part of this long-standing feature of medicine, which is there's a constant hunt for pharmaceuticals at the expense of other sorts of interventions. And had we just reflected a bit on whether or not that was likely to bear fruit, I think we would have ended up with a very pessimistic view. We've been looking for pharmaceutical interventions for viruses for a long time, and we've had some successes in medicine. So antiviral therapy for HIV or for hepatitis C, these are some of the kind of blockbuster breakthroughs in medicine in the last generation. But our ability to intervene pharmaceutically on respiratory viruses is basically a laughable joke. And it's not for lack of trying. I mean, we've really tried. There's a huge incentive to come up with, say, pharmaceutical intervention for influenza, for example.
Right.
So there's been all this effort to look for pharmaceutical interventions for respiratory viruses. Basically, in a nutshell, those have been failures. So we should have had a pretty good sense that they would be a failure for COVID as well. Now, there were these groups that were just counting the number of randomized trials that were being performed for various kinds of COVID interventions. And these groups were counting on the order of thousands of trials that were testing pharmaceutical interventions for COVID, and only a few dozen trials that were testing so-called behavioral, environmental, and social interventions. That seems to me like a complete waste of labor. And a lot of those trials were sort of DIY trials in some small clinic in some random place, unblinded, uncontrolled.
Okay, so ultimately, then you are supporting the evidence-based medicine hierarchy, but you also critique. You're also aware of the limitations of that hierarchy, right? Which is, and I was just kind of struck, kind of reviewing the book, and some of the arguments of pro-mask scientists, right? And they look at the RCT data. Okay, there's really no effect or very small effect, and then they'll sort of argue, no, we need to have evidence-based plus framework, which incorporates all of these observational studies, and there was a recent review in Clinical Microbiology which sort of, in my opinion, massaged the evidence to say that masks were highly effective, et cetera. So you kind of have these different competing visions of how to critique evidence-based medicine. And also the Cochrane review on masks was also criticized by the same sort of group. What was sort of your reaction to that?
Yeah, good. Thanks for that question. I mean, one thing that is sort of clear to all commentators about these sorts of questions is just how politicized these questions became. So when that Cochrane review came out, it's in simple terms, they were saying the wrong thing politically, and they were criticized for it. Now, the Cochrane review, as you're referring to, they reviewed randomized trials of the effectiveness of masks, and they basically concluded masks aren't effective. And that was controversial at the time. Of course, there are criticisms of the evidence-based medicine commitment to randomized trials. There are certain conditions under which we should take into account other kinds of evidence, like mechanistic evidence or non-randomized populational studies. I don't think any serious thinker is a sort of a die-hard advocate of always needing RCTs in any circumstance. But when we have a good RCT, that goes a long way. And by mid 2021, we did have a really good RCT, namely the Bangladesh mask study. And what happened with that study itself is extremely interesting and revealing about some problems in medicine and medical communication. So can I just speak to that for a minute?
Yeah, sure.
So effectively, that trial was published in the world's most important science journal, namely Science. And the article claimed to have found evidence for the effectiveness of masks, and they reported what's called a relative risk reduction of 10%. Those scientists wrote an editorial in the New York Times with the title, "We did the research, masks work." Now, what they didn't do in that publication is report the absolute number of subjects in the different groups that in fact had COVID. And so commentators quickly asked the scientists for that data, and it turned out that of the 350,000 people that were randomized in the trial, there were 1,086 subjects in the mask group who got COVID, and 20 more in the non-mask group that got COVID. So 20, a difference of 20 over 350,000 people. Now, there's a kind of technical debate about the appropriate ways to report such data, and I do this in the book a little bit. I argue for so-called absolute measures.
Yeah.
And if you report this data appropriately using an absolute measure, you get a reduction in risk of something like less than 0.1%. So are masks effective? The Bangladesh mask study seems to me fairly compelling to give us a negative answer.
Yeah, there was a reanalysis. It's published in a journal I think called Trials. I forget the name of the authors now, even though I've communicated with them, where they essentially have. And there's been a number of these reanalyses, but that's a great example, right, of the overstating of benefits. And you can kind of put yourself in the shoes of these researchers in a way. You conduct a huge trial like that, right? It's a lot of effort. It's a lot of your time, and so you want to have this sort of promotional headline saying that you've discovered something to benefit humanity, right? And but unfortunately, I mean, it really does. What would you say is the outcome of that type of, I don't know, it's not fraud, it's over optimism? Like what's a term that you like to use to describe that sort of massaging that takes place?
Oh gosh, yeah. I mean, I guess it depends on the nature of the specific massaging. So very often what we see in medical research is actual massaging or withholding of data. I certainly wouldn't say that the investigators behind the Bangladesh mask study were involved in that, but they were certainly exaggerating the finding. So they were promoting a finding which was not justified based on the evidence that they had.
Right.
So now that kind of exaggeration is deceptive, and it could lead to a further deterioration of general trust in science. And one of the background issues at play during the COVID pandemic and all the various debates about policy responses to the pandemic was this politicization in which there was one group on this side who tend to vote liberal and trust science, and then there was this group on this side who tend to vote conservative and are suspicious of scientific experts. It's an unfortunate fact about Western society that we have this kind of siloed polarization, but this sort of exaggerating behavior in scientific communication arguably could further reify that siloing.
Yeah, right. So to get back to your thesis about medical nihilism, then, or would you say that conservatives are the medical nihilists and the liberals are the medical optimists? Or
I certainly wouldn't. I would hope that things don't fall out that way,
right?
Because I hope that the thesis is generally applicable.
Yeah.
So I hope that both liberals and conservatives will find the message compelling, and so yeah, I'm not sure exactly how to respond to that.
Right. Yeah. No. I mean, I also struggle with those sort of binary categories, of course. The question that I actually wanted to ask was, if you feel like going through the pandemic, if you feel like your thesis about this expanding sentiment of medical nihilism, specifically, you had mentioned in the top medical journals, right? And so within medicine itself, if you feel like that's sort of expanded or maybe contracted in reaction to the public discourse, what's your sense?
So that's a tough question, and I'm probably not so well placed to answer this question because I'm not a sociologist. I don't like track public understanding of science
Right.
or public trust of science. Some colleagues of mine do that. They would be better placed to answer that kind of question. I suppose a very plausible worry is the following. One of the main kinds of science that guided policy response during the COVID pandemic was model-based science. So, and as we all know, the Imperial College London Modeling Group in the United Kingdom was very prominent in this. So they were developing models that had very dire predictions about what would happen under various scenarios, and that led to extreme policy responses. And those policy responses arguably hurt a lot of people, and many people were suspicious of both the science and the policy response. And so a very plausible reaction to all of that, now I'm sort of speculating from the armchair here, but a plausible reaction to all of that would be a furthering of distrust of science, particularly model-based science. Now, this I take to be deeply worrying because another domain of science, which is model-based and policy-facing, is climate science. There, the models are, have been developed over many decades. There's constant hunt for empirical data to inform the models. There's constant checking between models. The sort of science involved in climate models is more like routine science, slow, peer-reviewed, careful work. But the worry is that the public might get sort of further distrust of science because of the work that went into the COVID response, and that could carry over to other domains of science.
Yeah. Well, and we also do have similar issues in terms of overselling particular models or claims about effects. But anyhow, let's leave the climate discussion aside here. Okay, so in the book you make this kind of call for what you call gentle medicine. Can you give us a sense of what is gentle medicine?
Sure. So gentle medicine is a kind of package of ideas, including things like the most obvious is in the clinic, physicians should be less aggressive with respect to their intervention than they currently are. Patients should be less expecting of aggressive intervention. So the kind of one of the main pillars of gentle medicine is not non-interventionism, but just less aggressive intervention. Then there are broader features of gentle medicine. So one is about the research agenda itself. The idea is that we should be devoting more research resources to things like exercise and diet on our health rather than pharmaceuticals. And other features of gentle medicine are about the kind of regulatory context. So in my view, part of the implication of one of the implications of the book is that it's too easy to get medical interventions through the regulatory framework.
Okay.
You can get interventions that effectively have a negative benefit-harm profile through the regulatory framework, and that's a problem. And so we need some, better regulation. Okay. So yeah, gentle medicine is a package of these kinds of ideas.
Right. Okay. More medical nihilism, let's say.
Yeah, medical nihilism in practice, in the
practice.
clinic, and yeah.
Right. Okay. So kind of final question here. If we were to face another respiratory pandemic in, let's say, a year or 2 years, do you think that this overselling of intervention effectiveness would be any different? What kind of differences would you envision or would you predict if you could be so bold?
Yeah, thanks for that question. So, I mean, you're putting your finger on a really big background worry that I and others have about our policy response during COVID. So, Lord Sumption raised this in his interview either with you or at another venue that I saw.
Okay.
The idea is that lockdown was like a Rubicon. So once we've gone through lockdown, we now know that we can lock down. And that's deeply worrying because on Lord Sumption's view, democracy itself is a very fragile institution.
Mm.
And I'm of that view as well. So democracy itself, the freedom to walk down the street, to meet neighbors, to engage in commerce, to go to the grocery store, to fly to visit your elderly relatives, those basic freedoms we have taken for granted because we've been in democratic societies for generations now.
Mm.
But those are a fragile set of rights that can be too quickly lost, and that we should be constantly vigilant about protecting those rights. And during the COVID pandemic, we just too quickly gave up those rights, and we allowed our policymakers to enact policies that were deeply illiberal. So now that we've done that once, we have some indication that it could happen again, and it's plausible that the happening again would be easier than happening the first time.
Yeah.
So your question is really putting your finger on one of the sort of deep worries about what the COVID-19 policy response was. If another pandemic comes or any other kind of emergency, effectively the justification for lockdown during the COVID pandemic was we're facing an emergency, and therefore we need to enact some policies that are clearly not good generally, but are justified. Clearly we don't want to lock people down, but in this case they're justified on a kind of lesser evil justification, namely we're going to be saving a lot of lives. Now that kind of justification for the abandonment of fundamental liberal policies should be treated extremely cautiously. Through history, we have a lot of experience of governments appealing to emergencies to thwart basic liberties when they shouldn't have been.
Yeah, no, I mean, I agree with you. And it's interesting because I've been meeting with a number of folks who share these views, and some of them think, oh, no, the consequences of the lockdowns or the policy response in general are becoming more widely known. And yet it's about just the fact that you've set a precedent. And so another example, I met with an economist today, and in 2008, during the financial crisis, there was a sense that the Fed in the United States couldn't just bail out large banks, and they did that. And if you look at the last sort of 15 years of economic history, they just keep doing that now because it's a policy response that's now normalized.
Right.
And so the idea that public health is not going to lock people down or do these interventions again, I think it's a very naive viewpoint. I think we're facing a more likely situation where that would take place in my opinion. So
yeah, I agree. I in general, I like to have an optimistic outlook on life, but on this question, I'm with Lord Sumption. There is cause for pessimism, and I think that pessimistic outlook with respect to the sort of fragility of our democratic institutions hopefully motivates a particular kind of tenacity and care with respect to protecting them in the future.
Great. Well, thanks for joining us. That was Jacob Stegenga, who's the author of a 2018 book by the name of Medical Nemesis. Thank you.